Good morning, everybody. We have met here like a couple of months before to start our activity and stroke program in the Bahrain Specialist Hospital. I want to say that I'm happy to say that that would be the first stroke program in Bahrain in private sector. And actually, we deserve to have this one because we have all the components of stroke program to be initiated in our hospital and to move forward to provide the people of Bahrain with safety concerning the stroke activity and the program. So, does anybody have an idea about how many nerve cells die in a unit of time in 1 minute? If I have a stroke now, so there is no blood supply going to the certain part of the brain. Anybody having an idea how many nerve cells will be affected each minute? Of course, but if we have occlusion, so we have 2 million nerve cells which die every minute, and this will count for the disability of the patient and his recovery. Okay, so there are numbers to remember because those are the main two numbers that we are seeking to know in a stroke program. That in 1 minute, 2 million neurons die. Okay, so this means that we should act fast. صح? The second thing, the international benchmark of door to needle time. So since the arrival of the patient to the ER till he has received his treatment is 45 minutes in more than 50% of patients. So if I have 100 patients, more than 50 of them should receive treatment within 45 minutes, and it is accepted up to 1 hour. Okay? Our slogan is, which you will see from now on, is DTN less than 10. So we can achieve a record to be less than 10 minutes. Why we waste time? The waste of time is coming in the processes that happen in the hospital, from the triaging till the examination till the imaging and then insertion of needle or getting a lab. So we can reduce this time to the best time we can achieve. So this is our numbers to remember, and we will present those numbers later on. Okay. So as we said, that stroke is the leading cause of disability worldwide, and it is the third or second leading cause of death after AMI and cancer. And it is a neurologic deficit due to interruption of blood supply to the brain, to part of the brain. So it can affect speech, it can affect movement, it can affect balance, it can affect any of them, which we respond when the patient presents with what's called B fast. Do you know what is B fast? Yalla sir, B fast. B balance, E eye, loss of vision, F face weakness, A arm or leg weakness. Okay, so do we have children? Okay, so and the S is a speech comprehension. So the patient cannot understand what we say suddenly in less than 4.5 hours, or he cannot speak, not only just speaking, but even comprehension of words. 85% of strokes is ischemic due to occlusion, and the 15% is hemorrhagic due to rupture of the blood vessel. The result is interruption of blood supply to certain part of the brain. And the incidence of stroke, it is 50 to 200 per 100,000. Okay, so if you multiply this by 15 to be 1.5 million population in Bahrain, so we might reach 3,000 stroke case per year. However, everybody says, where are those 3,000? We don't see any of them here in the country. Okay, so those cases do not come to the hospitals because number one, lack of awareness. Because even they do not present to public hospital or they are lost somewhere. But this is the international incidence. So it cannot be less than 3,000, okay? And as I said before, so in King Hamad, we received like 300 stroke per year. BDF is similar, and Salmania might be more. So it will be like 1,200 per year. So where are the 1,800 which we didn't receive? They are lost somewhere. They are minor strokes which are neglected and could even pass to a serious complication like even death, and the people do not know, are not aware. So this picture is our goal, okay? So this one is, as just Dr. Najah explained, that the number of cells dying depend on the collaterals which are there, okay? So the stroke, this one artery is occluded, and then the start of stroke is it touch? Okay. The start of the stroke is small as that one. And we expect, which when time passes, we said every minute pass, how many cells die? 2 million. So 2 million, 2 million, 2 million, 2 million. So it grows to be bigger. So our aim is to intervene as soon as possible to revascularize the brain. And this would make the difference. If you have a good or a comprehensive stroke center, so everything is organized to do the intervention rapidly to revascularize. So 65% of patients taken directly to level 1 stroke care, they go independent without disability. And this study was to show the long-term disability of patients. And this does not come to be level 1 unless we cooperate and collaborate. So it is a stroke team. It is not Dr. Mohamed, no Dr. Mahmoud. It is everybody in this hall is involved in the stroke care. So what's called the stroke care team, okay? So we are going to talk about the stroke. The stroke in Bahrain is rising. Why? Because we have aging population, number one. Number two, we have a big percentage, like more than 50% of expats in the region. Most of those expats are of Asian origin, and they have prevalence of intracranial vascular pathology. Okay, so I see the youngest for whom had a stroke I saw, and it was big, large vessel occlusion. It was like 24 years old, and he was from India. Okay, I saw from Philippines, from Thailand. All those Asian subcontinent are exposed to higher risk. So number one, aging population. Number two, the expat in the region. Number three is the prevalence of vascular risk factors, which is high in the country, like diabetes, which is the major cause of stroke. So we have seen that there is rising of the stroke and recurrent strokes in the Saudi Arabia and the Gulf region. And as we said, we have in this country, in the Kingdom of Bahrain, we have half of population is the Bahraini, 3,000 stroke per year we have. So if we have 3,000 stroke per year, so we expect that is that about 20% of those patients, like I have 100 patients presenting to the hospital, 20% of them should be receiving thrombolysis, which is medication to dissolve the clot intravenous. And then some of those patients having large vessel occlusion, so they are supposed to do large vessel thrombectomy. So we go by catheter from femoral or radial artery to retrieve this clot and take it out. So in the 3,000, we expect to have like 600 thrombolysis per year and 300 thrombectomy per year. And the stroke activity in Bahrain is mainly in the governmental hospitals, which started in King Hamad University Hospital, then progressed to the BDF and to Salmaniya Medical Complex. And now we are considered, since we started our activity, to be the first private and the biggest center for stroke care in Bahrain. So there is what's called inter-hospital integrated care. So we should be able to transfer the patients between the hospitals. So suppose, for example, a patient coming to Ibn Nafis, and this patient got stroke, and they don't have a stroke program. When we announce that we have a stroke program, so they should be sending the patient until they may even build their program or they do something like that. but usually they prefer to send to the hospital. We have got this before when we were in King Hamad. So they were sending us the patient for treatment and he comes back. So there must be some sort of collaboration and networking and outsourcing. Like they do outsourcing for us. We should be like the stroke program of the private hospitals in the region. Okay, we can have this communications. If they don't have very well established stroke programs, they would do that because it is safer and we should publicize this. So what is the meaning of comprehensive stroke center? Comprehensive stroke center meaning that, I will show the previous one. So the first, the stroke levels of care are: number one, acute stroke ready hospital. There is no neurologist in the hospital. There is only internal medicine or ER, and they have CT scan, and they are interested in stroke. So they can thrombolize the patient, like an AMI patient coming to a hospital, and he couldn't be referred to another hospital, they can thrombolize this patient. Okay. Second level is the primary stroke center, where there is neurologist, there is CT scan, but there is no cath lab. So we can do the thrombolysis, which we said here that it accounts for 600 strokes per year thrombolized in the country. And then if he has large vessel occlusion, they refer him to the third level, which is the comprehensive stroke center. Luckily here in BSH, we have a cath lab. So we are able to be a comprehensive stroke center. Since we have a cath lab, we have a neurologist 24/7, and we have the imaging that we can use. So afterwards, we have, I might welcome my wife, Lamia. So interaction and the networking between different stroke cares is a great potential for Bahrain Specialist Hospital. So now if we see that in the right corner, there is the Bahrain Specialist Hospital, we should interact with different hospitals and we should provide the care, and even we should provide the support for them. If they have a case with a stroke coming less than 4.5 hours, maybe it would be at the end of the stroke of the window, we can treat them even there, and then they refer him to us. So we have very big potential to be a stroke center, even leading the others to start their activities, since they are going to collaborate with us in this regard. So when we are going to implement the stroke program, we should have a stroke unit. The stroke unit, not necessarily to have a stroke unit. We can have virtual beds in our ICU. We have a 6 beds ICU. It's wonderful. We have our team is great there. So we can assign virtually, like bed 1 and 2, they are stroke unit in the hospital. So the preference of admission, it would be to this place, okay? It should be usually close to ER or imaging. So the best thing to reduce the door to needle time, which is the time from patient coming to the hospital until he is taking the medication, it should be reduced as much as possible. So the first step after imaging should be thrombolysis. So we are going, and after I take your suggestions and opinion, to choose one room which is next to the CT scan, to equip it so that the patient starts the thrombolysis before even transfer to ICU. And this is what we have done also in King Hamad. So the thrombolysis room was just next to CT scan, okay? And we have the CT scan and MRI down in the floor. But what happens also, to integrate all our things, like from ER, the patient passes to the CT scan, we should not lose any time in this distance. This is why we created the clinical pathway and the guidelines of acute stroke policy in Bahrain Specialist Hospital. So we and the team, I had led many sessions, like 3 or 4 or 5 meetings with the hospital teams to adapt the stroke policy and the program to BSH. Like, for example, one, I don't remember, Sarah, if it was somebody mentioned that we have the elevator. So when a stroke code is activated, so one of the elevators should be kept for the patient to go down. When we have announcement of stroke code activation, so the technician of the CT scan should be there, and he would empty the CT scan. So the next on scan would be the stroke patient. We will not put, like, for example, any other case, except if it is necessary. Yeah. And then we integrate everybody to facilitate the reduction of door-to-needle time. One of the things that I discussed also with Dr. Morhaf is the availability of CT technician for 24/7. They said that there are 4, and the 4 is very good number to have a 24/7 coverage for CT scan. So with proper scheduling, I think we can achieve that. But this is optimal, not to call him from home. Like the CAS lab team, I have dealt with them. They are very rapid. Okay. If we have a stroke program and the CT technician are involved in this one, I think they would be very well responsive. Suppose we don't have them in-house, so we can provide them with a room or any place where they can be seated or nearby. Those have things to resolve, multiple options or multiple solutions. So this stroke program and the clinical pathway stemmed from the international standards and the evidence-based medicine from the guidelines of early management of patients with acute ischemic stroke, which started to be evolving since 2018 with the modification. So it is all evidence-based. Then we moved to the manpower requirement of stroke unit, okay, or of stroke system. So we have all the medical teams necessary for that. We have the neurologist, we have neurosurgery on call. Okay, we don't have to have a 24/7 stroke. Neurosurgeon in a stroke like cardiac CAS. So cardiac CAS needs to have 24/7 cardiac surgeon. And then we have the ICU team, Dr. Zakir, ER team, and this ER team here is wonderful. And neurosurgery, anesthesia, and we have access to other subspecialties to discuss with them. So we have physiotherapy team, which is I saw we should develop also our physiotherapy and the rehabilitation in BSH, because it is the main biggest source for stroke care afterwards. And actually it is the, like we say, the bread and butter of stroke. So we have the elite thing, which is acute revascularization, and we can grow up a very excellent system for stroke recovery. Speech therapy, we can have access to them. As discussed with Dr. Qasim, we can integrate some people to be with us for the treatment or management of physiotherapy. However, for acute speech and swallowing assessment, we always train the nurses because they are already available for assessment of swallowing, because the most serious complication of stroke is aspiration pneumonia. Okay, and this is one of the leading cause of death. So it's easy, and there are programs to train people, and we have in the ANGELS guideline and the all stroke care guideline, we have access to train the nurses for acute swallowing, acute stroke swallowing assessment. Nutritionist, social worker, and all the team. So those can be trained, and this is what we are aiming to do. Sasi came. Okay, so we have also at 9:30 another meeting with the heads of nursing from ER, ICU, and education to start the educational program for our colleagues. So material requirements. Do we have material requirements? We discussed previously with the lab and with the pharmacy that we need a POCT test, which is point of care test for creatinine, because all those patients will do CT and CT angiography. The CT angiography requires creatinine. Actually, in the guidelines, we don't have this. If you have stroke, they tell that the neuron over the nephron, but I don't want that since we have MRI. So since we have MRI, we can do MRA. However, but the MRA is lengthy, and so the CT scan is the standard. So this is why we do creatinine test rapidly as soon as we can. If it is normal, so we pass the patient to the CT scan for CT angiography. If it is abnormal, we can provide this so the patient can do the MRA. Okay. We have also the point of care test for glucose, and we have the point of care test for INR. The INR is very important because if it is below 1.7, so, and this also a stick test, we proceed with thrombolysis. What I discussed also with the lab that we should be a later than that. So we can provide a service with the assessment of the novel anticoagulants, which is DUAC, because most of people now, they are, for atrial fibrillation, they receive DUACs. And those are contraindicated for thrombolysis within 48 hours of ingestion of the medication, unless you are able to measure the level. So this test does not exist in the whole country for the other programs, and this will lead them to send the patient to us. If he has, he will, because it's very precious. Okay, the beginning of any program, we get those that they will not, but they send afterwards. But I saw many resistances in some things. So for the equipment, we asked about the point of care tests for ER DUAC assessment, and we have neurosonology. As you see, Dr. Najah, you have already, I heard that you got new machines for ultrasound. Those machines are able to see, like we see here, this is the transcranial Doppler. So we are able, bedside, to see the vessels of the brain of the patient. And there is even more advanced thing called sonothrombolysis. So it aids in the disintegration of the clot. And the Dr. Qasim shared with me some information about in UAE, they have the ultrasound also a treatment for Parkinson. So they can use the ultrasonic machine to do like non-invasive surgery for the basal ganglia to help the Parkinsonian patients. So for the diagnostic equipment, we have the CT scan, we have the magnetic resonance imaging, we have the Doppler sonography, we have CT MR angiography, we have the CT perfusion, this number 5. It is a software that could be uploaded to our system, to our CTs and MRIs, which calculates how much of the brain is taking blood, how much is suffering from lack of blood supply. And then we put, and this very important thing, the rapid software. The rapid software is exactly helping us to get the result of CT and MRI on our mobile application in less than 10 minutes. So this is even faster. It is artificial intelligence tool, and I will show it right now, which shows us exactly the location of the occlusion, shows us how much of the brain tissue is okay. Is the patient eligible for thrombolysis or not? And this one is FDA approved. So it is not, it is used already in other hospitals, including King Hamad and in Saudi Arabia. They have this one. Echocardiography available also, and we should have a remote access. And this remote access is, I think it is an IT-ish thing. So for the patient, for the doctors responsible for the decision making for stroke, they should have a remote access. This is in the form of teleradiology, but this teleradiology is not only for them to read it, because it's needed for the neurologist himself and the interventionist. Yeah, so this means that he can see the assessment, he can do the order for the CT, for the, not only for the PACS, but even for the MR. And then he can see the medical condition of the patient, if it is available, if it has any contraindication for thrombolysis, because those are very important and necessary. Especially, as I said, even if Dr. Mahmoud is living beside the hospital, until he comes here, he will take not less than 10 minutes. And in these 10 minutes, as I said, 2 million neurons every 1 minute passing. And this is, even this remote access, it is already on the rapid software that we see. So this is, we should be unique and recognized. So this one is the rapid software. So we see here, it comes to our mobile immediately. The CT scan is done, and all the data from the CT scan raw data is pushed to the server. And then it comes back to us with the result. So it shows us here that there is a bleed. This is on the mobile application. And it shows here that there is occlusion of the middle cerebral artery. It shows here the penumbra. So if we see the pink one is, sorry. So the pink one is smaller inside here than the green. So I know the green is the area which doesn't have blood supply, and the pink is the area which already died. So if we do subtraction, we see that there is tissue which we can save. So this patient is candidate for thrombolysis. But if the pink equals the green, this means that the whole area which doesn't receive blood supply is already all dead. So this will also let us not to proceed further for mechanical thrombectomy or for other things, because we don't have salvageable tissue. This is important very much in the area between 6 hours to 24 hours. So if a patient presenting up to 24 hours, we can do still mechanical thrombectomy for him, provided that he has a viable tissue. And here also it shows us the calculation of this one. And even it is less than, as technology, it is a license. So it is less than the salary of 2 radiologists per month. And then it is helpful also not only in neurology, but in pulmonary embolism and other things. So it is very rapidly evolving nowadays. This is the one I was just telling you about. This is a software should be applied to the machine. This one, it's called the CT perfusion. And it shows us the difference here. As I told, this is the area which is already dead, the red. This is the area which is hypoperfused. So it is very evident that there is very big area which will suffer if we don't intervene, and it will benefit when we intervene and we treat this patient. So this will come by integrated education and the continuous training. And those images, we involve there is one, Boehringer Ingelheim, in fact, they are the company which do the thrombolytic agent and the tenecte place for the heart, but they have separate and worldwide institution called Angels. The Angels provide training for non-North American regions all over the world for development of stroke programs. So it is not difficult to achieve or repeat the regional stroke network by extensive awareness campaigns. And then we are seeking to get the ESO certification, which is the European Stroke Organization certification, and the World Stroke certification, and they are actually free of charge. We just upload on the system our registry. So number one, Yasara, we should have a registry. And the registry, we will upload this data to the server to see our times. It is just searching for our KPIs. So door to CT, door to needle time, and the door to puncture time. And then they compare it. If it is within the range, we get awards up to platinum and the diamond certification. So we need to maintain high quality stroke program through training, operational, medical, administrative. Everybody, even I spoke with Dr. Ayman yesterday about the financial aspect of integrating a stroke program. We are a private hospital. If we say that we have a stroke program, everybody will come. We need to make it dealt with as urgent basis. So without verification of insurance. And this one, we should have a formula which benefit also the hospital. We are not going to spend all our money for treating the patients, and we don't again or even lose. This will destroy the idea from the start. But I have developed solutions for this one in the different in Saudi Arabia, in the UAE, and here. So this depends on the insurance capabilities of the country and how much we will gain if we can arrange this. We are, me and Dr. Ayman, we are coming up with some formula to present to you how to get the most benefit of this one without harming the patient, because we can do also the primary tests, and then we do transfer of the patient through networking if he is not able to pay. And then the continuous supervision, there must be stroke program office, stroke program coordinator, performance improvement, and stroke committee monthly from the stakeholders that we have met with, and the creation of policies and pathways, and it will be renewed. And we must improve and involve the telestroke reinforcement. I spoke with Dr. Qasim and Mr. Majid about branding of our stroke program. So if you are affiliated to some of the hospitals internationally, this means that everybody in the region, in Qatar, in Saudi, they come to us Why? Because we have a brand. And this is what happened. I maybe also discuss this in King's College, UAE. So the King's College London, they have branch for movement disorder. And everybody is going there. They have now more than 50% of their patients coming from Saudi and Bahrain, 20% from Bahrain, 30% from Saudi. And then we need to attract those patients. I will come to this point in the coming slides. So there are many big areas. This is like a tree. We build the core, and then the branches will develop by itself. So there is pre-hospital stroke management, acute revascularization therapy. This is the one we are achieving now. Immediate post-stroke care, long-term stroke care, and community awareness. So we need to treat the patient even as soon as he arrives in the ER after the CT scan. And this is one of the patients who was in Mohamed. He arrived and we treated him in the ER, not in the stroke unit. So that to start early, then shift him to the stroke unit. And now, if you see his right hand does not move, and then after thrombolysis, he is able to move his both hands. We have also, this figure just shows for people who do not know thrombectomy. This is the arteries of the brain, okay? The middle cerebral artery, which is mainly responsible for the weaknesses and the inability to speak. And this is the anterior cerebral artery. Here there is an occlusion. Here is after revascularization, okay? We go by a means of catheter from the femoral artery or radial artery to reach this clot and take it out. This is the angio machine. And then the most important thing is we develop our comprehensive rehabilitation program, okay? We need physiotherapy, occupational therapy, swallowing function and rehabilitation, exoskeleton training, hydrotherapy. This could be developed. Actually, as you know, Dr. Qasim, Mustashfa Al-Musa, they developed very big hospital for rehabilitation in the Bahrain area. And this means that it is a really demanded service. So they had another two centers like what's called the Cambridge Center, and they were offering very good service. And despite that, they are still developing rehabilitation and inpatient rehabilitation tools. So having a stroke program by default will have stroke prevention clinic. And this also will help the inter-hospital referrals. So a patient with cardiac problem should be referred to the stroke prevention clinic. Patient with the endocrinology problem like diabetes should be referred to the stroke prevention clinic. Vascular clinic should refer patients because those are common shared risk factors. So we are developing our in-hospital stroke network. And this facilitates diagnosis and assessment of stroke risks. This will also give us very good reputation that we have this one when we publicize this stroke prevention clinic. Okay. In addition to that, coming afterwards, this one, we were able to develop subspecialty clinics like headache clinic, like movement disorder clinic. The most important thing and very lacking in the country here is the movement disorder clinic. And then this is a master class, which I'm faculty with the King's College in UAE. As I said, they are receiving more than 50% of their patients from outside UAE. And they receive King's College building, it receives about £2 million from Emirates to King's College to get those visiting doctors. We can approach to get those patients without get those doctors coming to here after or besides their visit to UAE in our hospital, and we develop this one in King's College in Bahrain. Actually, they are trying to build this in Jeddah. So we need to, we will speak about that later in details. That something, if we are interested, we can talk with them and we can propose the idea. So time is the most important factor. As I said, it is important to decrease the number of neurons which died. And it is important also to be in the global or world record. We could have a time that permits us to get the awards that we need to have. Thank you.